I will now invite Dr. Robert, who is actually our overseas faculty. Dr. Robert is well known to us. He's an associate professor at St. John's Medical College in pediatric surgery, and he is on a fellowship now in Australia. Got 1 or 2 more years to go when he'll come back and join the faculty there. Dr. Robert.
Thank you, Dr. Ramchandra. The title of the talk sounds very polite when it's in English, but the original thing that came in mind was "Yaru helidhu olle result anta." So I think it translates too easily to English. Thanks, Dr. Ramesh and the organizing committee for giving me this opportunity to come back home for a visit. It's a good excuse to come back to be with friends. So to get on with what I have to say, with hypospadias, a result looks really beautiful. It looks beautiful on the operative note. In fact, with my patients, you notice the result looks best on my operative note. And then slowly as time goes by, you see that doesn't look nearly as good as that. And that's what got me thinking initially to see that what is a great result. And then you see it in most of our follow-up articles which are seen in pediatric surgical urological literature. They all have to do with the surgeon's perspective of what he thinks is a good result. And I thought I'll take a critical look at that. So you might see me doing a little bit of a devil's advocate role here. Forgive me for that. So as you all have been taught that beauty is only skin deep, and especially so in urethroplasty, because we are trying to reconstruct a tube which is designed to carry urine at high speeds and propel it, at the same time designed to carry semen at a completely different speed and propulsive capabilities, using the spongiosum, which has a special elastic capacity to do these both things. And we are replacing all of that with skin. And therefore, the premise on which we start off saying that it's a great result while we're using the wrong material is the humbling factor in hypospadias. And while it may look cosmetically good, we go back to our old saying of beauty is only skin deep. And a lot of our operative notes look like that. In fact, every operation of mine has looked like that, trust me, on paper. So the question is now, who judges this? Who's the judge? Who can say that this is a great result? Who can actually honestly look at it? So I thought I'll break it up into these 4 groups of people as to what does the surgeon himself say, what does the operating surgeon or the urologist say about his own patients, what does the psychologist say. There are a few articles about that. There were a few good questions coming up when Dr. Ravi Kumar was presenting, so I'll come to those articles. Importantly, what do the patients when they are young say, what do the same patients when they are pubertal say, and what do their parents say as this thing is going on. A few articles on that, and I think what you'd like most is what other surgeons feel about the result of hypospadias, and there's a nice article on that as well. So traditionally, the outcome measures which we follow up on our outpatient clinics and we follow up in our articles are basically to do with stuff we can observe as an anatomical problem, which is a fistula formation. We are able to say if there's a stenosis, the number of times somebody has had an operation, or if there's a diverticulum in the long run, and things like that. There's been a felt need for both objective and reproducible outcome measures, and there have been many criteria which have been elucidated right from the 1970s. There have been many people who've put in their own protocols to see how to evaluate, and all of them have to do with where the position of the meatus is there a caudy, and what is the scar like, and what does the scrotum look like. And it has stopped at that. We'll also look at how different a surgeon's perception can be from the patient's perception about the same organ. And we'll also look at some non-surgical factors in outcomes which are as important as the surgical factors. So to start this off, and so what does the surgeon say? Muria is one of the guys who's got most of these articles in the early stages. I think he'll be one of the pioneers when this is looked back on in terms of function of the hypospadias patient. And he did this study where he compared what the patient, sorry for that, the patient's perspective and from the surgeon's perspective. From the surgeon's perspective, it is very familiar. These are the things which I mentioned in the morning by Sanjay Rao as well. These are the usual things that we look at when you're looking at hypospadias result, and these are the things that we can correct, and we're spending today and tomorrow looking at these correctable factors. But if one goes down to look at something else which the patient actually is concerned about, and these are the ones which have come out in that study, the ones which distressed patients most were the volume of the glans, the size of the penis, and the thickness of the penis. And these, as we know, are uncorrectable. And therefore, it wasn't surprising in this study when they looked at their results with satisfaction about the appearance that the surgeons were uniformly very well satisfied with the result of their hypospadias repair in these patients. And the same patients were unhappy because they were looking at 2 different parameters. They were looking at 2 different things. And this success does not translate to success in the real world for the patient. And that is room for disaster, because most of us are able to look after our patients for a year or two, look at it and say, pull up your pants, go away, you're perfectly normal. And then there is still a minefield of trouble there for that particular patient, especially if he's unhappy. So another article which looked at what the surgeon feels about the result himself was from Baskin. This is he brought in the concept that rather than looking at these patients in the clinic and going by the notes, that he would accurately, photographically record pictures for 181 patients, a beautiful study where he had pre-operative, immediate post-operative, and then about 6 months to a year, a post-operative picture, and collated all three together and then analyzed them. The only weak point being that he analyzed them himself. There was no independent observer who was analyzing them. And he looked at these four things. Again, what the cosmetic outlook was, the mucosal, the furlet collar, whether it was satisfactory, the final location of the meatus, and the configuration of the meatus, whether it is vertical or horizontal. And so a whole series of pictures, and most of us are familiar with penises which look like that. They look really good, and the results do seem quite satisfactory. But unfortunately, the outcomes in these are very black and white. Was it successful or unsuccessful? There was no spectrum, and therefore the success rates came out as excellent in most of the new patients which he operated on. Especially so in patients who had two-stage operations, the success which he reported was about 100% in terms of the appearance. And you can look at the numbers which are here, about 96% and 95%. And all of this was the success rates in the patients who are coming in fresh, whereas there was a lower success rate in complex redo urethroplasty. But I think the biggest weakness of this model was the fact that it was not an independent appraisal. But that's what we surgeons are like. So we now move from surgery to somebody else who's now getting very interested, and that is where I think trouble is going to come, because there are not too many articles in the past about the psychologists who are coming in to evaluate our patients as they grow into adolescence. And this is one of the papers from the UK, wherein they looked at non-surgical factors, nothing to do with the 5 factors we spoke of, correctable things, but the non-correctable things. And they have this thing sorted out, that a genital body image, which I haven't heard of before, positively correlated with the terminal meatus position. And this they have it on their studies, in that study which came through, that if the meatus was at a normal location, that translated to a better genital body image. And the better the body genital image, better the psychological function. And their study was basically prompted by a few patients who were adult, who became offenders, sexual offenders. And then 2 of them actually in court took recourse to the fact that repeated operations on their penis was construed by them as abuse. And therefore it was, at least their lawyers got them off scot-free. That is what prompted an article like this to go back and see if there is a bigger number of patients who might be struggling with this. And therefore, when we're concentrating on getting the meatus to a normal location, to a terminal location, we're actually not just looking at the function, but we're actually laying the road for a healthier body image, which definitely has been shown to have a psychological function. No matter what people say about size not mattering, there's actually very little research which actually says that size matters. And in hypospadias, that is a particular problem, because in about 20% of hypospadias have a reduced penile length to start with, because of the factors which Dr. Ravikumar mentioned. And it's not only shortened at the time of the operation, but as they go to puberty, because of the lack of the DHT and the receptors, and so that doesn't respond nearly as well as those in the normal patients. And therefore, the question of size in hypospadias does become a problem. There might be a more functional building, but then people still are impressed basically by the tallest building. So going on to what the psychologist says in these, they have actually 2 groups of patients which are there. A study looked at people children who are 2 to 6 year olds who've had hypospadias repair when they're very young, and looked at their follow-up and found that that there is an increased withdrawal in them, and then they're very aggressive children, and there's more of a sense of inferiority, shyness, and enuresis. On the one hand, this does sound scary, but on the other hand, it sounds like a lot of normal children. And the problem is that the control patients who they've compared this against are children who've had herniatomy operations. Uniformly, they're using patients who have herniatomy operations. So we don't know if a child who's had a circumcision, which is again a penile operation, may react the same way as somebody who's had the hypospadias. When they're looking at the late outcomes in adolescents, then there are very varied reports there as well. The few psychologist papers who come out with that saying that these are more neurotic, they can't form relationships, and there's about 25 to 30% of them who never get into a long-term relationship or a marriage, and they're able to tie it back to the hypospadias. Another paper from Murillo in 1995, which mentioned that 20% of hypospadiacs had sexual inhibitions, which led to a fear of ridicule, and resulted in an older age at sexual debut, and also the fact that it led to them having fewer partners than normal controls. I personally wouldn't look at this as a side effect. I think a lot of our families will be happy if we give them that side effect. But it meant basically 3 or 4 years later of sexual debut in them. Braca, who looked at his long-term outcomes, was convinced that those who were satisfied with the cosmetic result, with the position of the meatus, with the shape of their glans, had an earlier onset of sexual activity with lesser inhibitions. Just to summarize the psychological outcome risk factors, we know this from our textbooks, and this is that when you operate outside the optimum age bracket, the severity of the hypospadias, and a direct relationship of that to the number of operations. The more severe it is, probably the more number of operations he has. And I think this is the one factor which we can actually change, is the child's or the parent's unfavorable view of the hypospadias. And that I think we have an opportunity to change that when you see them in our clinics. We see them before the operation. We set the rules there, and we tell them that what we are doing is purely an anatomical correction, but then to also to help build on them to a positive body image which goes on through. And when we know that our mothers can be obsessed with the way that the child's penis looks in questions of family and things, we tend to brush over it and to say it's all fine, but I think it probably needs a little more help. But the danger with all these psychologists' articles is the fact that a lot of them are suggesting that maybe intensive counseling or cognitive therapy be employed. There have been 2 articles which are suggesting that these 2 to be employed. But there's an equal number of people who are saying if repeated visits back as these children grow older, grow into adolescence, to point out to them that there is something wrong and going back to their genital image might actually be detrimental in the long run, where the child is trying to run away from that little abnormality. And to support this, there are patients who've had distal hypospadias, who've never been operated, who have an excellent quality of life, who have an excellent function, who didn't even know they had a problem. So there's a lot here which we don't know. So coming on to what do patients say? Sorry, Ramesh, I'm running a little late. What do patients say? This was a self-administered quality of life questionnaire which was published in June 2008 in the Journal of Pediatrics. Just to summarize, that the self-reported quality of life was lower in children with hypospadias compared to controls. Again, the controls, patients who had hernia operations. They found that there was no difference in the quality of life reported by the mothers of patients who had hypospadias. And these are the 2 factors which they thought was the most important determinants, that as the patients grew older, they thought their quality of life was actually better. So the children who were going closer to adolescence in this study actually felt better about it and being less ashamed of their penis. They also suggested that there may be a good role for counseling in patients who have a poorer quality of life. Another question, this is the Pediatric Penile Perception Score, the PPPS. This was an instrument which was set up for patient self-assessment and for a surgeon evaluation. Came out again in September 2008, the Journal of Urology. 147 patients ranging from 6 to 17 years of age. So there wasn't uniform, the age there. There wasn't a good mix. And the questions basically were to do with the length of your penis, the position of the meatus, the shape, the axis, and general appearance, and that was the scale which they used. Now that concerns me a bit, because if about half their patients were between the ages of 6 and 8 years, and at that time these questions really can be a lot of suggestive answers, and the boy really hasn't had a chance to actually sit and compare, whereas the families who probably have more recourse to looking at other penises, they were slightly more unhappy than the controls in these patients. And they actually postulated that the families, the parents, actually may carry a secret guilt about a genital disorder in the boy, and therefore they continue to be unhappy. Coming to the last thing of what do other surgeons say. So the same study, what they did was they took 4 pictures of every patient in those views to make sure that you had a good look at all at the collar, at the meatus, at the torsion, and at the scar. And this was then given to blinded urologists. They had 6 urologists who they completely blinded to the surgeons who had done the operation. And they went across. And I don't know, looking at those pictures, when I saw it first time, I was very happy with those results. I thought they looked really good. And the questions were basically to do with the 4 meatal position, shape of the skin, shape of the glans, cosmetic. And the scoring were very simple. They said very satisfied, satisfied, dissatisfied, very dissatisfied. I wish I had time. I had taken a survey of you guys. But that study showed that this was from 6 colleagues who were blinded to who had done which operation, and not even one of those patients, and none of one of the urologists came up to saying that it was satisfactory. uniformly unsatisfactory, looking like that. So I get scared if they look at some of my repairs, what they would say. Right, and this was inter-rater reliability was actually quite reliable, and therefore I think they might be the best judges, because the fellow surgeons are our most critical, whether it's the person across the road or the guy in the same unit. And even though the patients had a very high score with those results, in the same patients, their surgeons weren't happy. And beauty is indeed in the eye of the beholder, as Dr. Ashley taught me a long time ago. So just to summarize, we've seen that as surgeons, we're simple people. When we see a meatal location which is terminal and cardiac correction, we are happy. We say, great result, thank you very much. Whereas the child and the parent, they're not looking at that, they're looking at a normal looking penis. And a normal looking penis for them is to compare to somebody else, to another child, to another person who they know of. And that is coupled with a good function in the future, which we don't know when we operate on them. And that is what is happy for them. And the psychologist, as we saw, hasn't heard of the word happy. So no matter what we do, they're going to bring up a body image and then make them really upset. So I think what I can take back from this is that set reasonable expectations for the family, explain to them that it's not just the meatus, that is much more than the meatus. And I think time and colleagues may be the better judges of our result, and wait until puberty before you say there. And we know great men have said mission accomplished and then taken their words back. So we shouldn't do that with our Hypospadias results. Get ahead, do it, make sure the boy is able to do what he's supposed to do, but have someone there who's able to keep a watch. Don't lose sight of our patient. Wait till he's pubertal. Come back, definitely have a look at him when he's 14 to 16 before we let him loose on the world. Thank you very much.
Thank you, Robert, for putting across very profound concepts in a very unique manner. Thank you very much. Anybody has any comments or their own experiences to recount?
Most children are very timid. Have you any explanation for that?
Timid.
Yes, they are not social.
Yes, sir. Most of those papers are looking back at the operation done at a vulnerable age when genital image is still being sorted out, but 3 to 5, which then turns them either into aggressive people or withdrawn people, and it affects their body self-image, which is why the age of surgery has been trying to go down. So it's a postulation, we don't know for sure. I'm only telling you from the articles I read, but it does seem to make sense, because 3 to 5 is the time when they're so concerned and they're forming their genital image, and there's a disruption to that, not just the operation, but repeated examinations and the mother's, the parents' insistence on something is wrong with that. So it might be to do with that. So you had a question about size. You had asked Dr. Ravi Kumar about andrology and things. So just a question there. There's only one article which talks about that, not in the context of hypospadias, but for epispadias and micropenis. There's one article which has looked at patients with micropenis and epispadias, where they've said that the sexual function was satisfactory. But the authors also said that he had only interviewed the male partner. Therefore, it is not something we can actually lay on an evidence and say that you have a problem with the meatus, I've put it up to the tip, it's going to work perfectly well. We don't know that.
There are references to say that they are...
Thank you, Robert.
Thanks.
We'll move on to the next session.